For all these things to work, whether it's a laser procedure or an intraocular procedure, what is one of the key factors of success? It is that we have a good tear film. And one of my companies, oh, it sounds nice, eh? One of my companies. We have in the eye care group, the president you have met, Jacob Abrahamian. We have a couple of products that will certainly help you to establish how the tear film is and what state it is in. We have the lateral group, that is what I'm going to talk about today. We have the myopia control group. We have an IOL group that Sudi will talk a little bit about tomorrow. And we have the laser group, and we have a slight interest in what was presented before in robotics. We have seen many reports on dry eyes. And so we thought that I will talk freely for the first couple of slides because it's the Jews and all that. We have seen throughout all the years that Sudi and I will work together that we have given many, many talks about the tear film, what impact it has on different surgical procedures, what happens to the tear film, and so forth. What we have not concentrated on at that time is the ocular surface pre-surgery. And we have talked about the Glycocalyx before, and it's worth mentioning again. And why is that? Because as soon as you touch the cornea with anything, or as soon as you touch the tear film with anything, you are interrupting the Glycocalyx in the tear film. Now, what is very interesting here is that the Glycocalyx is not present in the basal cell layer. It's the next layer up where you will find the Glycocalyx. And as soon as you touch the tear film, you are interrupting the Glycocalyx action. The Glycocalyx action is like a glue that helps the tear film stick to the microvilli. And so touch is definitely not on when you are investigating the quality and the quantity of the tear film. We've heard a lot about goblet cells. We have the tear, fantastic instrument in the tear lab, but it's too expensive and too cumbersome. The Blepharitis patient, or any patient above the age of 60, do have problems, or some kind of problems to a certain degree, with eyelids. We did a couple of years ago when I was back in Sweden, a survey, and all our cataract patients started 2 weeks before surgery. That was the waiting time in Sweden. I know Pavel operates them the same day, more or less, and some others do as well. But what is important here is that they clean the eyelids properly and used artificial tears. So it served two purposes, really. That we had clean eyelids and the patient knew how to drop. Because I'm aware of, and you've heard this over and over again, oh doc, it's so difficult to put the drop in, right? You recognize it? It's there. In the Blepharitis patient, we also have something called Demodex. And these are small animals, and they are contributing to a certain degree to the Blepharitis. Dry eye syndrome is, of course, one of the most frequently encountered ocular morbidities. Even in the general practice, the doctor will hear, oh, I've got dry eyes. The prevalence of dry eyes is estimated to be somewhere between 7 and 33%, depending on what study I'm citing. So the impact of dry eyes is there, and it is easily treated, of course, but how to treat it and when to treat it, and can I prevent my patient of not having good quality vision after surgery by helping the patient to have a better tear film. This is one of the slides that's been circulating around the world for many, many years, and it actually shows my eye. The top left picture is just after blink, and the lower left picture is about 15 to 20 seconds without blinking. And we superimpose those on top of each other, and you can see the result of a very nice tear film there. It's a tear prism, really. So, the tear film stability tests. Normal blinking maintains the flow and have the tear film to be stable. What you are all using is the tear breakup time. Here, it's a very simple test, but you use fluorescein. You are touching the cornea. Normal breakup time is considered to be about 10 seconds. So, as soon as you touch, you're interrupting the tear film and the glycocalyx will go away. What we are advocating instead is the non-invasive breakup time. It's very easy to measure, whether you have a topographer or take out your old keratometer. You ask the patient to blink and then stop blinking and look at the Myers or look at whatever you have in the topographer, and as soon as you see that they start to get wrinkled or distorted, stop. That is your non-invasive breakup time. The non-invasive breakup time is usually about 15 seconds, so it's a bit longer than the other one. And it's much more consistent method than using fluorescein. There are a lot of NBAT tests, but this is the one that we advocate. Sudi we've been doing with a keratometer. There are modified keratometers. They have the handheld keratoscope, if you can get rid of a hollow one, or the T-scope as well. But the easiest way, get out the old keratometer and use that. You don't need to use it. The nurse can do it, because she can see it and count, hopefully. Tear prism height and speed of filaments, routine, again, look at the speed of the filaments in the tear film going towards the nasal duct. If it's a slow movement, then you know you have an oily tear film. If it's a rapid movement, you know you have a watery tear film. The volume tests, you're all familiar with this. This I don't need to go into. It's a 5-minute test, and it's bothersome for the patient. Extremely bothersome. You recognize it? So you have to, maybe you have to use anesthetics. 5 minutes, the accuracy is not there, and it's bothersome. So what we have developed in ECCG is the Lateral Meter. It's a paper strip, imprint. I hope to have it here, but the package has not arrived yet. Maybe tomorrow, we'll see. A paper strip is impregnated with phenol red dye. And the phenol red is pH sensitive and changes from yellow to red when it's wetted by the tears. You don't need to do any pre-tests. You hook it temporarily, and as soon as it takes, the test takes about 30 seconds. So it's a vast difference from the shimmer. It changes color from yellow to red. You can break it off because the strip is marked at the 10 millimeters marking with a line. If you see already after 15 seconds that you passed it, you can remove it and throw it away. The luxury pH we have developed in a similar manner with a pH sensitive material on the tip. It takes 2 seconds to touch, and you have a change of the color of the strip. If you have basic, then you know you have to have an acidic tear solution. If you have an acidic pH, you know you have to have a basic. Then you don't have any stinging as well. The stain tests. Rose Bengal, forget about it, because it's irritating and the patient could have an allergic reaction to this. Lysamine green does the same stuff, and it's much easier to see it. Here are some slides from Lysamine green tests. The hyperosmolarity test is from Tear Lab. I think that this is not for the common practice. It's too expensive and too cumbersome. And the question is how long it will be available. If you look at the OIS papers, their stocks or the share value is not doing too good. So the conclusions here, my friends, is very easy. Start with a NIBAT, check the tear prism, do the Lateral Meter, and do the Lateral pH, and that can be done within 2 minutes. And it will be at a very, very low cost for you. Estimated price for the end practitioner like you will be maybe $50 for the 2 paper strips, not more. Thank you.